Good afternoon. My name is Mitchell Thompson, and over the next 10 minutes, I will present a public health perspective on herpes simplex virus, covering both HSV1 and HSV2. HSV is one of the most common viral infections worldwide, yet it remains chronically under-recognized in public health planning because most infections are mild or asymptomatic. My goal today is to convince you that HSV is not simply a clinical curiosity, it is a population-level driver of stigma, neonatal disease, and HIV acquisition. We will examine its burden, risk factors, and surveillance, prevention, and community engagement strategies that frame a modern response. Here's the path I will walk you through. We start with what HSV is and why public health professionals should treat it as a priority infection rather than a benign nuisance. From there, we move into the global and U.S. burden, then into the risk factors and transmission dynamics that drive the epidemic. I will spend the middle of the talk on contemporary surveillance, screening, prevention, and treatment, drawing on CDC guidance and recent literature. We close with the community engagement strategies, health equity, and concise summary, and the peer-reviewed evidence base supporting these recommendations. Let's begin with the basics. Herpes simplex virus is a double-stranded DNA virus that establishes lifelong latency in sensory nerve ganglion, meaning once you are infected, you carry it for life. There are two serotypes. HSV1 is classically the oral cold sore virus, but in high-income countries that has become the leading cause of new genital herpes among young adults. HSV2 is almost exclusively sexually transmitted and produces recurrent genital disease. Both reactivate periodically, and crucially, most viral shedding occurs without visible lesions. There is no licensed vaccine, and antivirals suppress symptoms without eradicating infection. The scale of HSV is staggering. According to the most recent World Health Organization estimates published by James and colleagues in 2020, roughly 3.7 billion people under 50 are living with HSV1, and 491 million people aged 15 to 49 carry HSV2. In the United States, NHANES data shows HSV2's seroprevalence near 12% among adults aged 14 to 49. Importantly, prevalence is not evenly distributed. Incidence is rising fastest in adolescents and young adults, and the burden falls disproportionately on women and on racial and ethnic minorities, a disparity I will return to later in the presentation. So why does this matter to public health? 4 reasons. First, HSV is largely an invisible epidemic. Tronstein and colleagues showed that up to 70% of HSV2 transmissions come from people who do not know they are infected. Second, neonatal herpes carries devastating outcomes when maternal to infant transmission occurs around delivery. Third, HSV2 is the single strongest viral cofactor for HIV acquisition. A meta-analysis by Freeman and colleagues found that roughly a 3-fold increase in HIV risk among HSV2 positive individuals. Finally, the psychosocial toll, stigma, depression, disclosure anxiety is measurable public health outcome that we cannot ignore. Risk for HSV, like most sexually transmitted infections, operates across 3 levels. Biologically, women are at greater risk because of mucosal surface area, and any concurrent ulcerative STI raises susceptibility. Behaviorally, the standard drivers apply: number of partners, inconsistent condom use, and partnering with someone who is not on suppressive therapy. But the most important and least appreciated drivers are structural. Stigma suppresses testing, limited access to confidential STI services, contraceptives, and the burden of marginalized populations. And gaps in comprehensive sex education leave young people without the literacy to protect themselves. Public health programming must address all 3 layers. Understanding transmission is the key to designing prevention. HSV requires direct mucosal or skin-to-skin contact. You cannot get it from toilet seats or shared towels. The defining feature of HSV epidemiology is asymptomatic shedding. Detectable virus on the skin without any visible lesion. Tronstein and colleagues in JAMA 2011 paper showed that even people on suppressive antiviral therapy shed virus on roughly 10 to 20% of days. The implication is profound. Roughly 70% of new HSV infections come from people who do not know they are infected. That is why screening, partner notification, and routine condom use all matter. Clinically, primary HSV produces painful vesicular lesions, often with fever and tender lymph nodes. While recurrences tend to be shorter and milder, many infections are atypical. Fissures, redness, or itching, and a substantial share never produce symptoms a patient would recognize. For diagnosis, polymerase chain reaction on a lesion swab is the gold standard for active disease. In asymptomatic patients, type-specific serology that targets glycoprotein G2 is used to confirm HSV2. Viral culture has been largely replaced by PCR because of higher sensitivity. Recognizing this clinical diversity is essential to avoid misdiagnoses in primary care. Surveillance for HSV is frankly weak. We rely on periodic NHANES seroprevalence surveys, sentinel data from STD, surveillance networks, and incomplete vital records for neonatal herpes. HSV is not a nationally notifiable condition, so there is not case-level reporting, and most jurisdictions cannot tell you whether their HSV2 incidence is rising or falling in real time. To modernize, we should integrate type-specific serology into every NHANES cycle, leverage electronic health record networks and commercial laboratory data for syndromic estimates, mandate neonatal herpes reporting in every state, and pilot wastewater HSV2 surveillance in high-density populations like university health systems. Screening for HSV2 is intentionally targeted, not universal. The 2021 CDC STI treatment guidelines authorized by Workowski and colleagues recommend type-specific serology in 5 situations: patients with recurrent genital symptoms but a negative culture or PCR, clinical genital herpes without lab confirmation, asymptomatic partners of someone with confirmed genital herpes, people living with HIV for prognostic counseling, and men who have sex with other men at elevated HIV risk. Routine population screening is explicitly not recommended because in low prevalence groups, imperfect test specificity produces false positives that cause measurable anxiety and disclosure harms without commensurate clinical benefit. Prevention works best when layered. The first layer is behavioral: consistent condom use, reducing partner number, and abstaining during visible outbreaks. The second layer is biomedical: daily suppressive valacyclovir in the landmark trial by Corey and colleagues reduced partner-to-partner transmission by roughly 48%. Third is disclosure counseling, which improves partner testing and reduces transmission. Fourth, in pregnancy, late gestation acyclovir from 36 weeks plus cesarean delivery for active lesions has dramatically reduced neonatal herpes. Finally, vaccine research is active but unsuccessful so far. The Bell's Herpavac trial failed. Through mRNA and subunit candidates are back in clinical development. 3 antivirals are licensed for HSV: acyclovir, valacyclovir, and famciclovir. All have similar efficacy. Valacyclovir is the most often used for daily suppression because of once daily dosing, and resistance is rare outside immunocompromised populations. But individual treatment is only part of population control. We need expedited partner therapy where it is legal and permitted, HSV counseling embedded in HIV pre-exposure prophylaxis visits, comprehensive school-based sexuality education, subsidized antivirals through Title X family planning clinics, and public-facing campaigns that reframe HSV as a common manageable infection. Stigma reduction is a control intervention, not a soft skill. Communities are not the audience of public health programs, they are the engine. 5 channels work for HSV. Community health workers serve as trusted messengers in clinics, churches, and barbershops. Peer education at college campuses normalizes testing among young adults. Faith-based organizations, when partnered respectfully, can deliver stigma-aware sexual health programming. Online communities and moderated digital forums extend reach. Tele-STI clinics now offer at-home testing kits with virtual counseling. Most importantly, community-based participatory research lets affected communities co-design interventions and define their own outcome metrics. The difference between programs done to a community and programs done with one. Disparities in HSV are profound and rooted in structural inequities, not in individual behaviors. NHANES data analyzed by Bradley and colleagues show HSV2 prevalence among non-Hispanic Black adults is roughly 3 to 4 times higher than among non-Hispanic white adults. Among Black women aged 30 to 49, prevalence approaches 46%. Women carry almost twice the burden of men. These differences are driven by sexual networks shaped by residential segregation, by inequitable access to confidential STI care, and by differential prescribing of suppressive therapy. Men who have sex with men also experience elevated burden, and trans-inclusive screening guidance is still uneven across the U.S. systems. To summarize, HSV is one of the most prevalent infections on Earth, with roughly 3.7 billion HSV1 carriers and just under half a billion HSV2 carriers. The defining feature of its epidemiology is invisibility. Most transmission comes from people unaware they're infected, which is why surveillance, screening, and disclosure counseling matter so much. The burden falls inequitably along racial, gender, and sexual orientation lines, and those disparities are structural, not behavioral. Action requires a layered response. Antivirals, condoms, comprehensive education, ongoing vaccine research, and computer-led design. Public health succeeds with HSV when we treat stigma reduction as core control measure. Thank you. I welcome questions. These references support every statistic and guideline I cited today. They include global prevalence estimates from World Health Organization, the Bradley and Haynes seroprevalence analysis, the Corey-Vale-Cyclovir transmission trial published in the New England Journal of Medicine, and the Belch vaccine trial results. The Fanfare paper documents racial disparities in HSV2 trends. Together, these citations form a defensible peer-reviewed foundation for the public health argument I just made. The remaining references continue on the next slide and round out surveillance, treatment, and community engagement among evidence base. The remaining references include the foundational Tronstein-JAMA paper on asymptomatic shedding, the Walden-Freeman meta-analysis linking HSV2 to HIV acquisition, the 2007 European IUSTI guidelines for international comparison, the Panitti and Kimberlin paper on neonatal disease, and the Whitley and Rosman Lancet review of HSV pathogenesis, and the 2021 CDC STI treatment guidelines authored by Orkowski and colleagues, the single most authoritative U.S. document for screening and treatment decisions. Thank you again for your time. I welcome any questions that you may have about the evidence base or the public health recommendations.